mental state. So he has agreed to, I saw him in hospital, and he's agreed to see psychiatry. So I'd hope that at least can give some better clarity. But I think there is a problem, I think, as well about access to psychiatry or specialist psychiatry help. But I think GPs again are used to sort of dealing with patients older and frailer. But there is an assumption sometimes that a lack of interest and a sort of thinking you would be better off dead is a normal part of aging, which it isn't. So, and I say but the Tilda study said it was an association rather than necessarily causative. But that would be a worry. Now, in some countries which have introduced assisted suicide and euthanasia, there is like I don't think any country requires a psychiatric assessment, but sometimes it might be recommended, or whoever assessing the person might recommend a psychiatric assessment, but I don't think it's a requirement. Because again, I don't think you can require people to engage with psychiatry because of the nature of the illness. Now, I'm just aware I might be running into a bit of a problem with my own computer, but hopefully not. Okay, so yeah.
No, no worries. Thanks for that one. There was another one just after that, which so this person said, small but increasingly vocal individuals, medical and not, proposing voluntary euthanasia for the most difficult of cases where palliative care can no longer help. Are there instances where palliative care cannot alleviate a person's symptoms, whether it's pain or psychological issues or
Mm.
other things?
I think unfortunately there are cases like that. They're not that common, but I think we have to separate these things out. So although vocal individuals may raise this, the commonest reasons why people look for assisted suicide and euthanasia is loss of independence and fear of being a burden rather than severe physical or emotional distress. I think but I don't claim the palliative care is a panacea for everything, but I do think that good palliative care will resolve and improve a lot of people's problems. And I think if you're looking at the results in the end of life survey, definitely the bereaved family members would have thought the care provided in specialist hospice units was very good and very high, and people were very well cared for. I think the danger sometimes is that if there are particular cases where there are people who have very difficult or very troublesome suffering, it is that I suppose that sort of exceptional case. It's if you change the law to allow for an exceptional case, it is then very difficult to sort of say that you can't. Like, why would you create that exception rather than other exceptions? So I think a change in the law I would still be opposed to a change in the law. Sometimes I think sometimes when people are will describing patients having a family member having a very distressing death, sometimes when I listen to those descriptions, what I'm actually hearing is people talking about delirium. Now, unfortunately, like if people, delirium is quite common in sick people and older people, and very often it's reversible. But as people are getting older or closer to death, it's reversible. It's less reversible. And I think if delirium is not reversible and people are distressed and agitated, they probably need appropriate sedation so that the person themselves is not frightened. Because I think delirium can be very frightening because people don't know what's going on, may feel trapped or things like that. So I think maybe an under recognition of delirium and under management of delirium, I think can really contribute to patients having a very distressing experience and their family having a distressing experience. I don't know if that answers the question. I don't.
No, that's great. That's I think the person was kind of looking to have addressed, so that's great. And if you don't mind, there was one person asked two questions kind of just together, and I thought they were both interesting. One is well, the first question they asked was what number of people are in palliative care in Ireland? I assume they mean at any one time. And then the other one that the same person asked is how can the community at large help with these situations?
Okay. So the first question about how many people are in palliative care, I think the only figures that are counted are people who are referred to specialist palliative care services. So, and as I said earlier, I think a lot of palliative care is delivered by GPs, by hospital teams, by primary care teams. So they're not necessarily counted or in that way. I don't know the actual numbers, but the HSE does report every year on the number of people who are receiving specialist palliative care. So they have the HSE metadata. So I'm sorry, I don't know the exact number. So on the north side of Dublin, of the patients like who are effectively on the books of St. Francis Hospice at the moment, would be somewhere between 400 and 500 people. But most of the people who are sort of being supported by St. Francis Hospitals are people who are in the community, and they're either being supported by a community palliative care team or they tender a patient or day services. I'm sorry I don't have the number for the total in the country, but I say the HSE metadata does carry that number. There is the problem in Ireland about numbers, patients being double counted because there isn't unique health identifiers. So there's always that caveat when you're looking at numbers in Ireland. The second question then is, how do communities help? And I do think that I think for communities we are probably unfortunately an ableist society, so that there is that view that being able-bodied, like nobody being that you tend to sort of consider the world is designed for able-bodied people, and that if you're not able-bodied then the world is more difficult. And I think the world is more difficult for people who are less physically or mentally able. And that is, yes, a feature of people who've got progressive illness, but also that many people are living with physical or intellectual or mental disability. And I think, advocating for a better, more fair society, for a society that's less ableist is really important. One project that has been sort of running in different parts of the world, including parts of Northern Ireland, are what are called compassionate communities. And the idea about the compassionate communities is part of that is the idea that you're strengthening social organisations, strengthening voluntary organisations, but also creating a sort of a normality about that people can sort of talk about serious illness and death and dying. So in Ireland, like when somebody has died, there's a great outpouring of support for patient, not for the family of the deceased. So we're very good at providing that immediate bereavement support for the family, and very good at providing very meaningful funeral rituals. But I think I suppose the other things are like, what's the earlier part when people are living with serious illness, and how do you help? So just listening even to an ad on the radio this evening about dementia awareness, like, do you know people with dementia? Check in on them. The way, like, it's that idea of creating I suppose, a more caring community overall. And and that is for people who are living with serious illness, but also for the bereaved, because sometimes for the bereaved, that there can be a lot of support very early on, but like people can be suffering bereavement in a way that's completely normal for maybe 2 years. So it's not just that people are very supportive for the time of the funeral, the first week or two, but able to keep contact, keep support for people into the future. I think another part that people can do in relation to the community in general is this idea of thinking about advanced care planning. Nobody has to write an advance directive about their future health, but maybe something you might be thinking about, or somebody might say to you, if I were very sick, I would or would not want this to happen. To allow people to have those type of conversations. And whether those conversations are among friends or with family, to allow people to have those conversations. So that allows people express their wishes, what might be important to them, and that can then help in the future for healthcare workers who are working with them.
That's great. Yeah, you covered a good bit there. And one of the things you touched on was about you mentioned dementia, and just somebody was just asking specifically. I maybe answered it already in what you were saying there, but how best to manage best palliative care. Well, this question was more about residents with
Mhm.
advanced dementia in nursing homes. So, um,
So I think for resident advanced dementia in nursing homes, the challenge for in that situation is that for people with advanced dementia, they're really not able to express their wishes, but what's important to them. And I think if people are living in nursing homes with advanced dementia, what is really important is then to try and for the people who know the patient, I'm going to call the resident the patient, for the patient, who are the people important to them in their life, and what do the people, the broader sense of the family, what do the family think this person would want if they got very sick? Because unfortunately, sometimes people with advanced dementia, they may get an infection, and the nursing home staff get worried and think we should send them into hospital, and then they're in the ED, and it really doesn't help them. But sometimes the nursing staff in the nursing home, they don't have a choice but to send somebody into hospital if there's not clarity about what this person would want. So if you're living in a nursing home and you get an infection, and your doctor, or if you're living anywhere and you get an infection, your doctor or nurse says you should go to hospital because you need antibiotics by drip. If you're clear thinking, you said, no, I don't want to go. And yes, I know I should go, but I don't want to go. You don't have to go if you don't want to. But if you have advanced dementia, you're not able to express your current wishes. But I think that's where having some type of future care plan, so that if somebody has advanced dementia, that there is a future care plan about, well, what would be the best thing for this person? What would they have wanted? What did they ever say in the past? I say some people might have had an advance directive, which is very helpful. A lot of people don't have them, but a lot of people will have sort of wishes and beliefs. And then based on the wishes and beliefs, what would be the best option for this person if they were in a nursing home, and that they were becoming unwell. And I think, and you're always better trying to do these things in a planned way rather than a crisis of a Friday of a bank holiday. So I'd always think if people have, friends or relatives in nursing homes, to think about, well, what happens if they become unwell and what should be done and what's the best thing. And having that conversation with the nursing home staff who are looking after them on a day-to-day basis and with the doctors involved in the nursing home. So you can make a plan that maybe reduces the risk of them having things which are burdensome and not helpful, and increase the chance of having a more comfortable care in the nursing home and more comfortable death.
Yeah, thanks so much. That was definitely I think that covered most of what that person was wondering. And yeah, if you just have time, just a couple more because actually a good few of them come in there, but I'll just pick a couple out here if that's okay.
Yeah.
So one person asked, and I know you did touch on it towards the end of your presentation, but one person asked, how much of a concern do you think it is currently that patients could be coerced towards assisted dying, and how do you think legalizing it would affect that?
But I think coercion is a big problem. And I think, again, say a lot of, say, patients advocacy organisations, and again, older people advocacy organisations are very concerned about the people who are freshly coerced into nursing homes. So that happens. And I say the National Safeguarding Office would have very high reports of coercion and people being put under duress. So I do think that if something like assisted suicide was available and normalised, it's much easier, I think, then to sort of for people to say, "Oh, this, I would be better off dead. I would be better if this wasn't here, if I wasn't here," because they can have both overt and covert pressure. Because the overt pressure might be that people are saying, "Well, like I've had families sometimes say to me, well, like, we're due to go on holidays sort of in 3 weeks' time. So should we, will so and so be dead by then, or could they be dead by then, or you'd like them to be dead by then, so it doesn't interrupt the holiday." Like I've literally had people say that to me. So if they said that to me, they could easily be saying if it's just a suicide euthanasia was available, they could be saying that to the individual as well, because I think it is a worry I have, because I think people who are living with serious illness can be very vulnerable. They may not be well able to advocate for themselves, and then there could be people around about them who may be actively not advocating for them, or advocating against them for their own reasons. Now, there is this very interesting idea, which I don't think has happened anywhere yet in the world, but moving from a right to die because you feel your life isn't worth living or you don't want to be a burden on your family, to a duty to die because you're a burden to your family or to the state. Now, there are some ethicists that have argued that. Now, I don't think any country in the world has moved in that direction, but that is, if being a burden is a reason to allow for assisted suicide, could being a burden be a sort of a duty to look for assisted suicide or euthanasia? But I say no country has moved that way yet.
Thanks so much. And if it's okay, we just have one last one, and then if that's okay. So it's just there was a particularly good one here from someone in Canada. So they just said they're listening from Vancouver. They're a palliative medicine physician trained in Ireland. They said here in Canada, we're made medical assisted dying is legal. I've observed the slippery slope happening with growing concerns about a potential shift in practice and a noticeable gap in the development of palliative care services, particularly in rural areas as MAID has become increasingly accessible. In contrast, my experience in Ireland was that palliative care services and multidisciplinary teams consistently provided high quality. Um, One second now, it's gone away from me. High quality, compassionate support for people with life limiting illnesses, the difference in system development and resource allocation. So I'll just see, was there more to that, or was that what I was seeing? Um, yeah, so what they said at the end was the difference in system development and resource allocation between the two countries has been striking. So I was just wondering if you could just, I know that's a lot to deal with, just a quick comment on that, I guess.
So I think there has been work done and research done just looking at the impact of introducing assisted suicide and the development of palliative care services. And it has been, to date, has been sort of fairly neutral. And for instance, I think in the Netherlands, the amount of euthanasia that was happening in the Netherlands was actually a driver for the government to try and develop palliative care services. But I think Canada is a very good example of what can happen in relation to what's called the slippery slope, because it is like every other country that has introduced assisted suicide, but just developing, or it's actually euthanasia in Canada. It is like every other country, but just going faster in the broadening of its criteria and acceptance. And one of the things is, and the Canadians have, written papers about what's the economic advantage of euthanasia, and then if you extend it to other population groups, what's the additional economic cost savings that will come from euthanasia, because it is cheaper, rather than providing comprehensive support. And I think that can sometimes then be a driver, and particularly where things are difficult to get or difficult to access. Um, and I think introducing and normalizing euthanasia changes society. So it makes things which previously people would have thought untenable, tenable. And there was a famous survey in Canada a few years ago, one of these public surveys, and asking the public what they thought would be reasonable grounds for euthanasia. So something like 25% of the population thought that poverty or homelessness would be reasonable grounds for euthanasia. So that is the sort of concern. And as one of the famous Dutch ethicists said, like initially euthanasia in the Netherlands was introduced to try and deal with a difficult death, and has now been used to deal with a difficult life. And I think is just the challenge of it. And I say that's where, getting back to what I was saying earlier about, is our society ableist? How does our community help people? And if that's, and I think we need to be not ableist and more community supporting.
Thanks so much, Dr. McQuillan. I threw a lot of questions at you in the end, but thanks so much because you covered a lot there. And thanks to everyone who put in questions. We did take note of all the questions we got, so if I took a question when we get around to it, we'll try to address it in some shape or form in a future webinar, so we haven't forgot anybody. So thanks so much, Dr. McQuillan, and thanks to everybody who joined us. We had a good turnout this evening. Thanks to everybody who put comments in. Um, Also, just say we're going to send out the feedback form by email. So we really appreciate if you take a moment to send back any ideas you have about this or for the planning for future events. And as I said earlier, just let us know if you need us to forward a CPD certificate of attendance. Just to let you know as well, we're going to we always put our webinars up on our website, and we did get the video working with Professor Chachanov, but it's just by the time we did the questions and answers we're going, but we will distribute that to everybody who registered, or it will be on our social media. So we'll send you the link to his talk if that's okay. So thanks again so much for joining. Especially thanks to Dr. McQuillan. Really appreciate it. And yeah, thanks so much. So yeah, again, my name is Stephen, and if you check out hopeireland.org and hopefully stay in touch then. So thanks so much, and thanks again, Dr. McQuillan.
Thank
Have a
you very
nice
much.
evening.
Thank you. Bye now.